After that, we'll be having some discussion. Whoever has any questions, please feel free to put them in the chat box or just ask. And then after that, I will be talking on something else. First, I'll be presenting a case followed by that case discussion. So
Before
with that,
we start, I'm so sorry to interrupt. Ankit, has
Oh,
sir joined yet?
who's joined?
Dr. Bipin sir.
No, yeah, he's not here. He's traveling. So he's
Oh,
not.
okay.
Yes.
Thanks.
Yes.
okay.
Floor is yours, Upasana. Thank you so much.
Thank you so যত much. শাসনে জীবু বাক্য বাইজিক না
Thank
you so much. So today I'll talk on median of assessment in carpal tunnel syndrome. We know the hand has a very complex structure with lot of joints, bones, muscles, and ligaments. But we are going to talk on $1 million structure today, which is also called the eye of the hand, and that is the median nerve. And together with the carpal tunnel, they form the star structures in hand imaging. So we know that commonest site of median nerve pathology is in carpal tunnel, the carpal tunnel, which is a fibrous tunnel at the wrist. And it constitutes about 90% of all upper limb peripheral nerve compressions and 1 to 5% case incidence in general population. It was first described by Sir James Paget in 1854. He reported it as a post-traumatic atrophy neuropathy. In his first case, the median nerve got wrapped around the wrist and he had to amputate the hand to relieve the symptoms. And in second case, there is a fracture in the distal radial shaft and he put a splint for that. But the term carpal tunnel syndrome was first coined in 1938 by Morse. So going through some beautiful slides for carpal nerve related anatomy, if we remove the skin, first we see a long structure there, which is the palmaris longus tendon. It fused with the flexor retinaculum and continues at the palmar aponeurosis. Then this is the flexor retinaculum. This is the inlet to the hand. If we cut it, then we can see the long tendons of flexor tendons. They are passing through the flexor retinaculum. Then if we cut the, can you see my marker?
Yes, Upasana, we can see.
If we remove the palmaris longus tendon, then we can see this is the median nerve. It's coming out from the undersurface of the flexor rhizome superficialis here on the radial side and passing through the carpal tunnel and giving branch to the distal finger stairs. But if you notice very carefully, you can see another very small branch arising from there on the radial aspect. And this is the palmar cutaneous nerve. It traverses for about 2 to 2.5 centimeter with the median nerve. Then it pierces this antebrachial fossa and going to the palmar surface. And this is the afferent sensory nerve supply to the palmar aspect on the thenar eminence. So in carpal tunnel, this branch is spared because it is not passing through the flexor retinaculum, and hence the thenar sensation will be preserved. If we move little more distally, then we can see another branch going to the thenar branch, and this is another very important branch. This is the recurrent thenar motor branch, giving motor supplies to the thenar muscles. And there are few other small branches we can see. These possibly are the motor branches to the lumbrical 1 and 2. Coming to the nerve anatomy a little bit, there are nerve fascicles. The axons, they together grooved to form a fascicles, and few fascicles together, they form a nerve which is covered by the epineurium. The nerve is a very blood-thirsty organism. It consumes about 20% of our blood volume, while it constitutes only about or less than 2% of the total body weight. So it has a very rich capillary supply, also has its own nerve supply, but but nerve doesn't have any lymphatic drainage. So this fascicular pattern gives what we see in our ultrasound, very nicely depicted, the bundle of straw in long axis or honeycomb pattern in the short axis view. Coming to the flexor retinaculum, it's a tough connective tissue layer which roof over the carpal tunnel. On the medial aspect, it joined into it fused, get attachment to the scaphoid bone, and few of the fibers, it fused with a flexor carpi radialis tendon there. and it sent a deeper bend to the ridge of the trapezium. On the medial aspect, mostly it attached to the hook of the hamate and sent a superficial band, which is also called the palmar carpal ligament, and that forms the Guyon's tunnel. Posteriorly, it is supported by the carpal bones, and together they form a very narrow tunnel there, about 3 centimeter long, 2 centimeter wide, and it has a depth of about 0.8 to 1 centimeter, and it allows to pass the 9 flexor tendons and the median nerve through it. So there is definitely very limited space within it. So anything that causes compression of the tunnel or increased pressure within the tunnel will lead to median nerve compression. Usually it occurs in female more than 40 years, gradually onset, intermittent symptoms with sensory symptoms like numbness, pain, tingling. She used to wake up in the morning, in the night, and she used to shake her hand or put it by the side of the bed to get relief. But if it is not treated slowly, she will develop motor symptoms with weakness of the finger, with gripping movement, loss of fine movement, and finally there will be wasting of the tendon muscle. If the symptoms are bilateral, we always have to look for some generalized cause like rheumatoid arthritis, diabetes, hypothyroidism, or acromegaly. Repetitive strain, perimenopausal age, and obesity are definite risk factor. So there, from the long term, there is a continuous effort to describe confirmatory ultrasound parameter for carpal tunnel syndrome, but still the widely used, worldwide accepted confirmatory test is a nerve conduction velocity test. But why it is so? To know that, we should know a little bit about the pathophysiology of the carpal tunnel syndrome. So we know this is a nerve, this is the functional unit of the nerve. It is a body and a very specialized structure called action. Its function is to transmit the electromagnetic signal or the axon potential from one nerve, one neuron to the other nerve through the synapses here, as you can see, through the neurotransmitter. This action has a very special structure and it is covered by an insulating layer, which is called myelin sheath. This myelin sheath, together with the endoneural tube, endoneural fluid, they form a very protective layer, and it doesn't allow some harmful molecule or the axon potential to pass through the axon. So when the signal passes through the axon, it has to jump from one. There are some intermittent gapping in between, which we call the node of Ranvier. These are some sodium voltage gated channels. So the signal has to pass from one node of Ranvier to the next, and just like this, it will pass through the axon. So its velocity is very fast, about 120 meters per second in the peripheral nerve. But whenever there is demyelination, it will pass through the axon very slowly, so its velocity gets reduced, and that formed the base of the nerve conduction study. And in case of median nerve, if the velocity is less than 50 meters per second at the wrist, or the difference between wrist to diseased or the palm to diseased velocity more than 10 meters per second, then it confirms median nerve velocity conduction defect syndrome. So whenever there is compression, there is increased permeability of the endoneural blood vessels. There will be increased fluid within the nerve fibers. So there will be obstruction to the capillary network that will lead to ischemic injury, axonal degeneration, and fibrosis. Over that, if there is repeated traction over the nerve with wrist movement or exacerbated, it increased the dysfunctional environment and leading to further nerve injury. It's always good to know some clinical or do some clinical test before going for scanning. One is the Tinel sign that we all know. Another is Phelan sign that we ask the patient to put her hand in a prayer position or reverse prayer position. That will give rise to symptoms. But the most highly specific test is a carpal tunnel compression manually with a hand. Then that will produce numbness or tingling along the course of the median nerve. So basic sonoanatomy that is related to the carpal tunnel syndrome. We know the bony attachment, but the new thing I learned is the carpal tunnel, the flexor retinaculum is not a single sheet of connective tissue. It has 3 root component, discrete ligament, which are in continuity from hamate to trapezium, trapezium to pisiform, pisiform to scaphoid. and the distal two are more stable. So when we put a probe on the pisiform scaphoid line, then the bone, the carpal bone we see is the capitate and not the lunate. Though we say that the lunate is the inlet of the carpal tunnel. So this is the proximal carpal tunnel. We all know this very nicely. But the imaging of the distal carpal tunnel is a little bit difficult because of the high anisotrophy and its concave shape of the hand. For that, the bony landmark is the pisiform. As we move distally slowly, we'll see that the pisiform will go away from our view. Now we have to focus on the ulnar artery there and go distally. Slowly, we'll see the hook of the hamate as a triangular bony portion arising just below the carpal tunnel. Then we'll move laterally to see the trapezium, the tubercle of the trapezium, and we'll get the distal carpal tunnel there. Again, the imaging of common palmar nerve is very difficult. It's a very thin nerve actually. So from the pronator quadratus level, as we move distally, we can see something is going out from the nerve there. And just keep on focusing. You can see it's going away from the median nerve to the radial side. And finally, it will pierce the fascia and going towards the flexor capillaris ulnaris radialis tendon. It's easier when the nerve is thickened. Sometimes there we may see a bifid palmar cutaneous nerve, like here. As you can see, there are two structures moving along the course. You can see it there. In this case, we failed to find out the palmar cutaneous nerve, but we can see some fascicles along with the median nerve in the carpal tunnel. And as we move down, it will follow the median nerve up to its origin to the pronator quadratus level. So possibly this is the palmar cutaneous nerve that is seen within the carpal tunnel. And we should report the localization of the nerve in the carpal tunnel because it is important for surgery to avoid injury to the nerve. Looking at the recurrent motor branches is also difficult because it's in the distal carpal tunnel. It's just beyond the distal carpal tunnel. So we slowly go to the distal carpal tunnel level. And at the time when the median nerve starts branching, we can see some shadow going out from the nerve tangentially to the periphery. And this is the motor recurrent branch to the thenar muscles. And possibly this is the muscle to the lumbricals, nerve to the lumbricals. Little bit about the basal and synovial complex. We know we have a ulnar bursa and a radial bursa. Ulnar bursa is continuous with the little finger tendon, and this is the radial bursa. In between, these tendons don't have any tendon seat, but distally they have. Its seat is because it has to give attachment to the lumbricals. And knowing the lumbricals is very important because sometimes you may have more proximal attachment of the lumbricals that invaginate or incarcerate into the tunnel itself. So we can see the first two are unipinnate lumbricals arising from the profundus, but here it is a bipinnate lumbricals. The literal two. Yes. So in long section, we can see the lumbricals muscle. It's a very thin tendon going to the extensor root on the supersurface. So we all know actually the parameters, how to see a nerve in carpal tunnel. The nerve will be thickened, edematous, hypoechoic. We can actually see the zone of transition there. And it will be fuzzy outline. There will be notch sign that may be very subtle, as you can see here, or it can be very long and thin. And sometimes it gives rise to a dumbbell shape. And we can see vascularity. In normal nerve, we will never see a vascularity. But in active inflammation, we can pick up vascularity. But if it is a long-standing case and we don't see any vascularity, then it shows the chronicity of the disease. And finally, it will develop into the hypoplasia of the thenar muscles. And if it is not treated, then it will give rise to the complex regional pain syndrome. Elastography, I don't have much experience, but I know it's become stiffer, and if the in wave it is more than 40 kilopascal, then it's sensitive, it's accurate in 91% of case. We take the cross section of the nerve at the level of carpal tunnel inlet. 10 to 20 is mild, 20 to 15 millimeters square is taken as moderate, and more than 50 is taken as severe. But the most sensitive parameter is the cross-sectional area difference at the proximal carpal tunnel level to the pronator. This is the pronator quadratus level, and this is the proximal carpal tunnel level cross-sectional area. And if the difference is more than 2, this is more accurate with 98% sensitivity or accuracy. And that is because it's an internal comparative assessment of the median nerve in the same patient. But the first parameter we described that can be influenced by the other factors like age, height, etc. And the other things are the distal flattening ratio more than 3, or the anterior bulging of the flexor retinaculum more than 4 millimeter. The most sensitive nowadays the parameter is in dynamic study. We see the ulnar nerve transition of the median nerve over the tendons of the flexor digitorum superficialis. Even some study, they are trying to assign the severity of the disease depending on how much the median nerve travels on the dynamic study with the flexion extension of the hand. Look at the ulnar nerve deformance of the shape of the ulnar nerve. It easily can flatten and expanded, but in case of a symptomatic carpal tunnel syndrome, it is not seen. The movement is restricted, and it usually doesn't change the shape, and it's become very rigid. So this is another very sensitive test. We ask the patient to flex his fingers and do or the pinching movement, extension and flexion. Usually we have, this is the ulnar bursa, and this is the radial bursa. There's definite space between them. With flexion, the median nerve should fall into the space and going out with the extension. Like we can see in this video, it's going over the superficial tendon. And again,
sorry, Dr. Upasana, once again. I'm just requesting everyone again to please mute their mics, please. Sorry, please continue.
Okay. Then it's going in again and fall into the narrow space between the bursa. But in this case, this is a symptomatic case. We can say it's just lost. It's just a fall into trap in between the bursa. It fails to move out. So what else we see in the carpal tunnel? Besides the tendon and the nerve. And that is, you can see some connective tissues in between the nerve and the mesotendons. And these are the mesotendons or subsynovial connective tissue that connect the tendons to tendons and the median nerve. They maintain the vascular supply to the tendons and reduce the gliding resistance between the structure. So these are another component or the content of the carpal tunnel, and that we better see in a case. This is actually the synovium of the tendon is a double folded structure, as you can see here, and this is the mesotendon that carries blood supply to the tendon, and that can be better seen when there is effusion. And these are all the mesotendons we can see. And this is the synovial seat, and this is the mesotendon that carries the blood supply to the tendons. In fact, most of the 50 to 60% of the carpal tunnel syndrome are still said to be idiopathic, and it is suggested that possibly these cases are secondary to subsynovial connective tissue inflammation. There may be vascular mesothelial hyperplasia, ischemia, fibrosis, with less evaluated pathologies, and these pathologies can definitely restrict the median nerve mobility within the tunnel. We know the most sensitive parameter in a bifid median nerve is the distance of the pronator quadratus level to the carpal tunnel level, and if it is more than 4, then we consider it as a carpal tunnel syndrome. But still, we find little uncomfortable when the clinician says that we don't need radiologists to diagnose carpal tunnel. It's a clinical diagnosis.
Pani dede, please.
Then what is the role of the imaging? Our role is to find out the underlying cause. In cases of suspected structural anomaly, you have to look for that. In pregnancy patient, usually they presented very atypical presentation. There we have a role, and also post-operative follow-up and guided injections. Of course, it's good that we know that the nerve conduction study, it identified a level of abnormality without any information about the nerve status or its surrounding. So we definitely have a role to find out there. In 1960, Fallon described and popularized it. He described a far more common idiopathic variety of CTS and its pathological aspect, and ultrasound has a great role to play, indicating the causes and confounder of the carpal tunnel, like the intrinsic causes. With the flexion extension, if you notice, we can see something going inside the carpal tunnel. What is that? This is the incursion of the lumbricals into the carpal tunnel. That happens with everybody if we do the passive forceful finger flexion, but it is significant when it is extend up to the proximal carpal tunnel level, and if the repeated incursion with certain occupation can lead to carpal tunnel syndrome. Cobb et al. They describe a test which is called the first feast test. If we sustain a feast for 45 seconds and that will produce numbness, then it is suggested that this lumbrical incursion into the carpal tunnel is the causative pathology. In this case of median nerve compression, we can see something on the medial aspect of the hand between the tendons and from the tendons. And in long axis, we can see this area, which is continuous with the lumbricals. And this is the tendon, fourth tendon, profunda tendon, and this is the lumbrical muscles. It shows vascularity, so we think it's a lumbrical muscle, the fourth lumbrical muscles with myositis. And going to the video here, this is the area. As we move distally, we can see it is continuous with the lumbricals muscle, and in the MRI, we can see there is definite myositis of the muscle, and it is extending into the carpal tunnel level. Here is another case of median nerve pathology, entrapment, and we can see the distal extension of the myotendinous junction of the flexor digitorum superficialis muscle. And in dynamic study, if you notice, there is very less movement of the nerve, and it is continuously within the tunnel, and it is causing compression of the median nerve. The bifid median nerve with a persistent median artery is itself is an indication of a causative factor for CTS, and it can be seen in about it's usually associated with the median nerve pathology, usually bifid nerve in 70 to 76% of cases. Usually the persistent median artery should get regressed by 8 weeks of intrauterine life, but if it is persist or fail to regress, then you can see it. It's not necessary it to be present with a bifid nerve. Here is a median nerve in the carpal tunnel in another case, and you can see a persistent median artery there, and it's traveling along the median nerve into the forearm. But if you find some pathology, it becomes very interesting. Just see at the nerve, see at the artery and the bifid median nerve, suddenly it becomes swollen. And what is this? This is a thrombosed persistent median artery, and we can even see the collaterals around it. So it's definitely under cause of CTS. Again, there may be tenosynovitis. This is a flexor pollicis longus tenosynovitis. As you can see here, there are even some ganglion cysts rising from the seat, and you can see how the median nerve is swollen there, and it's become it's just tucked in the interbasal space within the carpal tunnel. And this is the MRI, another case of similar case, and this is another case showing the basal, ulnar basal tenosynovitis and compression. Coming to some extrinsic cause. this is relatively underdiagnosed. There is thickening of the flexor retinaculum, as you can see here. But how to measure the flexor retinaculum? We know it's not. It doesn't have a even thickness throughout. So it's recommended that we should go to the distal carpal tunnel, find out the thenar muscle ulnar point. This is the most extreme point ulnar on the ulnar side of the thenar muscles. Then this is our carpal tunnel, suppose. So this is the first referring point, and we measure it there. And on each side, 3 millimeter away, we take another 2 measurement, and then we take the average of it, and 2.5 is the cutoff value. A flexor retinaculum ganglion cyst that is compressing the median nerve, as you can see here. This is a volar ganglion cyst, but this time it's compressing the palmar cutaneous nerve. We can see how thickened the nerve is, and we can see the proximally the nerve is thickened, and there is a compression by the ganglion cyst. Sometimes there may be some extrinsic muscle that may be reverse palmaris longus muscle. The muscle is on the opposite side distally, and it is causing compression. Another rare condition where there will be palmaris profundus, it arises from the flexor digitorum, and we can see something is there, and it is continuous with the median nerve and fused with the undersurface of the flexor retinaculum and aponeurosis. It's another space occupying lesion within the tunnel. Even the more proximal attachment of the abductor pollicis brevis to the flexor retinaculum can cause compression of the median nerve. A lipoma can cause compression, as you can see here, or there may be multiple lipoma, but unfortunately, one of them is seen compressing the median nerve. This is some solid kind of thing we can see in the first metacarpophalangeal joints, but in operation it is found to be a deep ganglion arising from that joint, and it's compressing on the carpal tunnel from the extrinsic side. Some infections, it's following some insect bite, he developed some inflammation and infection on the hand, as you can see here, and there is gross edema and positive carpal tunnel syndrome. This is diabetic patient. You can see the collection on the dorsal aspect that extend to the medial side on the thenar eminences, and it's very difficult to find out where is the median nerve, but on long axis we can see the compressed sign of the median nerve compression. Patient is symptomatic. Look for the Hansen disease. And coming to some arthritis that can cause synovitis and alter the carpal bed and causing compression. Tenosynovitis cause in rheumatoid arthritis, or very destructive case in case of juvenile rheumatoid arthritis. Even gouty arthritis also of the wrist, we can see all signs positive here that can cause rheumatoid arthritis. Not to say about the advanced cases of gouty arthritis, where you can see large nodules compressing on the underlying structure. And this is the synovial bursa, and you can see it's filled with the deposits there, possibly that was the median nerve. Whenever there is fracture of the distal radius or any bony injury and patient develop acutely the median nerve symptoms, then we call it as an acute CTS. Here is a scaphoid injury, and we can see the hematoma compressing it. This is a glass cut injury. It just cut the median nerve just proximal to the carpal tunnel. And this is another case. It's a 2 or 3 month old case. We can see the median nerve going. It is absent some part. There are some scar tissue. Then again, we can see the median nerve distally. And this is a complete disruption of the median nerve with scar tissue, as you can see here. A stump neuroma of the median nerve following injury. But there is something more inside the carpal tunnel that we usually neglect. What is this? That is the ligaments. That is the ligaments, and we shouldn't forget that there are many intrinsic or extrinsic ligament in the hand. And it's a case of injury showing disruption of the radioscaphoid lunate ligament there, or this another radiocarpal ligament, radioscaphoid capitate possibly, And these are absurd. In these cases, there may be disruption of the normal carpal bone orientation, and they can lead to median nerve compression. Look for any median nerve mass there. This is one case we have a cross, very inhomogeneous mass in the hand, and it's coming, extending medially and encasing the median nerve, and it was come out to be a malignant nerve seed tumor of the ulnar nerve. This is another hand mass causing all the symptoms, and it came out. It has also scars in the skull. Also, it has another mass, and it came out to be NHL. This is a post-operative case. Even post-operative case also we need to see very carefully. There may be some complications. We can see it's a bifid nerve, and the medial branch of it showing it's encased in the skull and shows fibrous neuroma formation. In post-operative case, we rarely see any change in the median nerve diameter or the thickening or the compression or the notch sign. Even it is increased in the distal part of the medial nerve. But this patient, she fails to move her thumb following the carpal tunnel release operation, and this shows all the pulley, A1 oblique pulley and A2 pulley, all are taken there. And this is a known complication of carpal tunnel release finger. This case was operated for carpal tunnel syndrome, and she again failed to move her hand and the median nerve compression again. And you can see there is no tendon of the flexor superficialis tendon there, and it got again disrupted. This is the profunda tendon, possibly partially intact. There is complete disruption of the median radial artery with thrombosis, and there is a complete disruption of the median nerve with a long distance gap. The patient is symptomatic. Suppose for the median nerve entrapment, carpal tunnel assessment is absolutely normal. What you will do? Just stop and look back. Don't forget the median nerve has traversed a long course to come into the gateway of the hand. So there must be something that is left behind. So it can get entrapped above at the level of the structural ligament, or at between the two heads of the pronator teres in the bicipital aponeurosis, or in the sublimis, at the level of the sublimis, or its exit from between the flexor digitorum profundus and superficialis. Then you compare the symptoms. There will be no night symptoms like carpal tunnel. There will be more motor weakness in the thumb and all the fingers. Sensory symptoms of the thenar palm will be there because there will be involvement of the palmar-cutaneous nerve. Aggravation of the symptoms by pronation supination movement rather than flexion extension of the wrist, and the carpal tunnel provocative test will be negative. So this is a pronator teres case I have presented it before. As you can see, the thickening of the nerve at that level because of the increased thickness of the pronator teres muscle. This is a case of acute compartmental syndrome causing compression of the median nerve at the forearm. This is a hemangioma between the flexor digitorum superficialis and profundus. We can see the close proximity of the mass to the median nerve. Even the median nerve is thickened and increased vascularity. We can see some hypoechoic areas within that is filled with blood. And I thought the median nerve also involved in the hemangioma, and it is confirmed on surgery. Another case, the patient fails to do the OK sign. It fails to show the OK sign, and we can see a deep hemangioma there on the volarix, just proximal to the wrist, and see how the interosseous space is increased there on the symptomatic left side, and possibly this is the anterior interosseous nerve that got thickened due to compression. This is a young man with say left hand and forearm pain. He is he's a drug addict, and he used to take injection. Possibly he misfired the injection into the muscle that leads to severe infection of his hand with necrotizing fasciitis and poems. You can see the necrotizing evidence of fasciitis there, and there are some hyperechoic small shadow, if you can see. And these are the segment of hypodermic needles that leave behind, and he develops thickened fasciitis, necrotizing fasciitis, myositis. These are all abscess and neuritis of the median nerve, leading to symptoms of median nerve compression. So out of these cases, still I have some basic questions in my mind. Like in this case, we can see a long knot sign at the level of the carpal tunnel, but there is also distension of the distal segment as well as the proximal segment. This is at the level of quadratus ventris, it is 3 square centimeter. At the carpal tunnel, it is 11, and at the median nerve outlet, that is the carpal tunnel outlet, it is 23, and the distal branches are normal. Another case that shows a normal quadratus level cross-sectional area, that is 7.9. At the inlet, it is 10, and at the outlet, this is 15 centimeters square. So my question is, where to measure the median nerve in this case? Should we take the maximum thickness of the median nerve and compare it with the normal thickness of the median nerve at the quadratus level? This case, we can see a single median nerve at the level of the pointer quadratus. As we move into the carpal tunnel, we can see it divides into 2. So how to measure the parameter in this case? This is a hand infection case showing extensive infection, and we can see there is a distal flattening ratio of the median nerve is very high, about 5.2, and this is the median nerve at the carpal tunnel level. We can see a thick perineurium this is covering. So should we measure it? Should we include the parameter? In the parameters, should we cover the perineurium? Should we measure the outer layer of the perineurium? Or if we measure the perineurium, then it becomes high. Otherwise, the cross-sectional area median nerve is normal. Or in this case, we can take the distal flattening ratio as a sole evasive parameter to call it a carpal tunnel syndrome. So there are many challenges to be solved. As EVC is operator dependent, we need a standardized image protocol for measurement of the parameter to diagnose carpal tunnel syndrome. We don't have any longitudinal parameter to diagnose carpal tunnel syndrome. It is said to be non-reliable by some studies, but others said it may be helpful as it is directly showing the segment of compression. There is no evasive parameter that predict the possible disease progression or postoperative outcome. Treatment decision making. Do ultrasound indicate that? Do we need to consider the morphological variations according to the race, sex, weight, height, age, while diagnosing and assessing the severity of the carpal tunnel syndrome? Does cutoff value can be altered by different disease population, like diabetes, hypothyroid, acromegaly, etc.? So we are still seeking many possible answers for approach to a potential future. We still need a large-scale epidemiological survey to solve these challenges. So finally, thank you so much, and open to discussion now.
So thank you so much, Dr. Upasana. I think that was a huge variety of cases of carpal tunnel syndrome or other pathologies which present as carpal tunnel syndrome. I mean, quite a few of them, even I haven't seen them. So it's quite an eye opener. So
tell me, stop there. Okay, I'm stopped. Okay.
Great. So anybody has any questions? Please feel free to ask. So Dr. Upasana has mentioned the important parameters that you need to measure, include in your report. So that's what it is. Yes, Dr. Nidhi?
Yeah. So,
Yes.
Upasana, I first have a query, and then we'll discuss few of the things, because we would definitely want to send a very strong message as to what parameters should be considered as a sonologist, as a radiologist, to give an effectively, if not 100%, but at least within the range of 70 to 80% a diagnostic confidence by doing an ultrasound. So, Upasana, you remember you showed us a video where you're doing a dynamic scan, flexion and extension.
Yes,
And then we see the tendons in the carpal tunnel, and we see some hypoechoic elements, which you said were lumbricals.
yes, ma'am.
Would we have lumbricals there?
No, sometimes, ma'am, the attachment of the lumbricals may be more proximal.
There is a very huge study in Science Direct where with the flexion and extension, there was one of the parameters that they took was part of the musculotendinous junction of the flexor digitorum superficialis muscles entering into the carpal tunnel and going back, creating a volume effect. So,
Yes.
like in CTS, there are descriptors which say that there could be three parameters. There could be an increase in the volume that leads to CTS. There could be a decrease in the volume with thickening of the flexor retinaculums. And the third is the inflammatory. So in that, they said that what enters comes in the carpal tunnel and goes back, and those muscles that you see could be of flexor digitorum superficialis. So lumbricals would come from the metacarpal, go up there and attach to the phalanges. So I would be surprised if all those could be so many lumbricals coming in.
It has proximal attachment to the flexor digitorum profundus tendon.
Correct.
It is
Correct.
attaching proximally to the flexor digitorum profundus tendons.
Yeah.
And I found cases, and I go through some literature, and they says, even I did it in my hand also, and
Yes, I did it in my hand too. That's exactly what I'm saying. Because
But-
when you do it in your own hand,
I can see the incursion of the muscles into the carpal tunnel. They said
Correct.
if we don't find any other cause, then
Correct.
it can be a potential cause. And if it can be occupational, suppose the person is doing constantly the same thing,
Correct.
then it can lead to the carpal tunnel syndrome.
Okay.
And Cobb et al. They described the test, the first phase test. They
Okay.
asked to hold, if the patient is symptomatic, we are not finding any case, and we can see the lumbricals. If
Yeah.
it is going more proximal to the proximal carpal tunnel, then it is it is more prone to develop the carpal tunnel syndrome. Then ask the patient to keep his fist tightly for 40 seconds, then it will produce the symptoms like
Right.
numbness and tingling. Then it is.
So I was when I was doing it and I was going through this study, I thought it was part of the flexor digitorum superficialis musculotendinous junction, because when we do that flexion extension, but it could be, you say, lumbricals. Tomorrow I'm going to have a look at it. That's very interesting fact that's come up. Okay. Anyone? Any questions? So if you have to summarize Upasana 1, 2, 3, let's just today narrow it down to 3 measurements that would give us diagnostic confidence. How would you want to rate that?
I think they say the most sensitive one is the distance of area between at the pronator quadratus level and the inlet level. If it is more
Okay,
than
so that means inlet and outlet.
Yeah.
You take a CSA
Yes.
at the inlet, that is pronator quadratus. Then you take it at the carpal tunnel, which will be probably the hamate, around the hamate area.
No, it's an inlet, ma'am. It's in the inlet of the carpal tunnel.
All
Where
right.
the maximum thickness of maximum thickness of the median will be there at the proximal end of the proximal carpal tunnel to the pronator quadratus level. So you usually doing this, ma'am, always. And the normal.
Upasana, see, we have to make things easy for everybody, right? Okay. So when we are doing, that flexor retinaculum is just like that small. And when you're actually doing it, you are always a little confused. Where is that carpal tunnel? So if we give certain landmarks, so like I take my inlet I take my
Inlet.
inlet at pisiform, right?
Yes, ma'am. That
I
one.
take my inlet at pisiform. For me, that is the distal wrist crease of the pronator
Yes,
quadratus.
ma'am.
So I
One
say
little.
that's my inlet. Is
Yes.
that correct?
Uh-huh.
Ma'am,
Huh.
pronator quadratus is slightly more
More
proximal.
higher.
It's at the level, yeah, more higher.
Yeah, more
So
higher.
so what Upasana is saying is you take it at the level of pronator quadratus, that is level 1, and the
Okay.
distal crease, what you're saying is level 2.
Two.
So pronator quadratus and distal crease. So these are the two standard areas where we measure.
But let me come here, Ankit. We go to the pronator quadratus.
Ma'am,
Carpal
pronator
is
quadratus will come slightly more
correct.
proximal.
और 12 सेंटीमीटर ऊपर आएगी, 12 centimeters above the distal crease. अभी तो, but when we are talking of carpal tunnel, that's the carpal tunnel.
Yes,
Is
that's
that
right.
so?
Yes,
है ना? तो
yes,
इधर तो
yes.
carpal tunnel आ गई, because that's my pisiform. This is my scaphoid, and somewhere down here is the hamate. And so when we are talking of carpal tunnel, we're just talking that small area. That small area. है ना? इधर जो ये इधर पर बन रहा है, that is practically our carpal tunnel area. So how I do it is that if you kind of just bring your palm in this manner, the small groove that gets created is practically the carpal tunnel. Am I correct?
Yes,
That
ma'am.
one.
Indeed. Yeah.
So now when we are doing it at pronator quadratus and we are doing it at the pisiform level, which is like the level 2, you say that that is the most sensitive area. I mean, the most sensitive parameter.
It's saying that that is the most sensitive parameter because we compare these two measurement in the same patient. It will not be affected by other things like age, sex, height, and all these things.
Correct.
So they said it is accurate in 98% if the difference is more than 2.
Okay. Okay, fine. All right. So that is one part correct that you're saying that at the pronator quadratus, very high up, and then you come to distal crease and
Yes.
you take the difference at this level.
Mhm.
Yeah.
Yes.
And if it is greater than 2, you said greater than 2 millimeters, we say that this is carpal tunnel syndrome.
Yes.
All right.
It is
The
more
second,
I think dynamic study is very important.
so you're not putting down CSA, absolute value of CSA at any level where they say 9 to 15, 9 to 11, 9 to 12.
Yes,
Absolute CSA
that is
value.
one parameter, ma'am. But literature says it may be affected by other. That is the question now. If it is, if we put some level there, like 9 to 12, 12 to 15, more than 15. But that can be affected by height of the patient, than the other things like age of the patient, race of the patient. So the
Yeah.
question is, can that parameter be affected by this? So to put different level for different disease population, yeah, some height regarding some height or age.
I totally get it, but Upasana, and I think Ankit, you or Rajas, and anybody who's practicing very rawly, everybody join in. When the orthopedicians are talking, they actually give a lot of importance to the CSA. They want to know 12. You know, for an orthopedician, I don't know if you had a conversation. For them, 12 is the cutoff. 12 millimeters square. Ankit, am I right or not?
Yeah, 12 is also there. Yeah, I mean, I would use 10 in my
10.
day-to-day practice. But yes, if it's at least 12, then it's significant.
Yeah,
But
for an orthopedician, it's an important thing that they want to know. Hi, Dr. Ketkar, how are you? Yeah, everybody join in. So there are
Ma'am,
studies. There is a
comparison with
study.
the opposite asymptomatic wrist, the complete absolute value with the opposite asymptomatic wrist, if we
Yes.
compare both sides on both the sides, ma'am, is
think
that
I
will
think that's
the
a
height,
great
the
idea.
weight, everything will be nullified in that?
Yeah, but because there is a study that has come out of Hong Kong, which says, and they have categorically said that at the inlet, they say 9 millimeters square, and in the carpal tunnel 7 millimeters square, and absolute CSA says rules out CTS almost by about 99%.
That's true.
And absolute values are.
Mhm.
So Do you agree or you don't? Because see, there has to be a guidance are saying that, this does not hold a lot of credence because of race, weight, height, yes. But then there are two very important things. As Gina said, you could have a side-to-side comparison. And the second thing that is very important is the patient is symptomatic. So if the patient is symptomatic, isn't falling in that range of 9 to, like Ankit said, 10 millimeters square. So there is a 9 to 11 millimeters square is the cutoff. There was once, Rolly also presented a case in which she had said, and I had asked this question to her, and she had said that, ma'am, 9 to 11 millimeters, the cutoff, which is a standard cutoff followed world over. So I would think that we need to give a CSA cutoff. Should we not, or we should? Let's take a consensus here.
We are following that, ma'am.
Yeah, we are. So if we are following that consensus, I think we should put it down as
used
at
to
an
put it
absolute
in our
value.
report also.
Huh?
It's moderate, severe. But okay, I mean, I wanted to surgeon is at the carpal tunnel inlet.
Yeah. Right. So that is, I think those two parameters should be, and then of course you can keep adding the Palmer bowing of the retinaculum, how
Yes.
much. We can keep adding on to our descriptors, but I
Mhm.
think the CSA and the wrist is to forearm ratio, is that what you call wrist is to forearm ratio, or you call it just the CSA ratio? Upasana, the one that you said 2 millimeters?
Wrist to forearm ratio, ma'am.
Wrist to forearm ratio. So wrist to forearm ratio and an absolute CSA, I think, should be two parameters that should go, and then we could always do a dynamic scan. I loved that what you said about the median nerve, not only the side to side movement, but it following up. That's the test that you do with the flexion of the wrist that was first demonstrated by Dr. Manik or Van Hulsbeek. And I remember he did that at ESSR. And that was the first time he demonstrated way back in 2014. So that's a great thing. So, and we didn't, I don't know if anybody had that experience about the accessory muscles of the wrist causing the carpal tunnel. Anybody has any experience on that?
Well, that is a potential cause for carpal tunnel syndrome because it's
Yeah,
ultimately acts as a space occupying lesion.
it does. It does,
Uh,
and it actually looks like, yeah. And
yeah.
particularly of the index finger, which is very common. We can have the
Okay.
index finger, and the
Mm.
flexor digitorum superficialis is an accessory slip which goes, and it is the commonest one which causes the carpal tunnel syndrome. So when you move, when you're moving the tendons together, it's very important that you do one at a time in order not to miss the accessory muscle causing the carpal tunnel syndrome. So you move one finger at one time in order to understand if there is an accessory muscle of the flexor digitorum superficialis.
So one more
Uh,
point was, yeah.
no, I
So
just
one more,
wanted to very
yes.
recently, ma'am, one neurosurgeon, a young neurosurgeon has started asking me, I mean, when we examined the carpal tunnel, he has started, I mean, he like asked me to like always comment on the recurrent motor branch. And I was like, I was not confident about it. Like he was more concerned about, that he wants to see the recurrent motor branch. So like how accurately can we see it, ma'am? I was thinking next time I meet you, I'll have to ask
These
you
are
to show
two,
it to me.
these are
Yeah.
the two branches that you should be seeing very, very carefully when you're doing CTS. One is the palmar cutaneous, which,
Palmar-cutaneous do we see, but do we need to see the recurrent motor branch also, like
well, then you
regularly?
need to examine, and maybe he found something there which says that the recurrent branch could be involved in some
Because
sort of.
he said that I'm going to like operate and I just want to see the position and because I think it's called the
Yeah, but
million
that's a
dollar
very
nerve and
variable position of recurrent branch. Very
yeah.
true. Recurrent branch of the median nerve has got a very, very variable position. And
Hmm.
yes, it is a good idea for us to, because, and the entrapment of that recurrent in between the aponeurosis between the flexor digitorum superficialis and the profundus, right, at the distal end, the commonest entrapment of the recurrent branch is right here. So it's very important that you should be able to see the recurrent branch and to rule out that there is no entrapment of the recurrent branch. It's a very good rule to follow when we are doing CTS.
So
I
one of
don't do it routinely. Yes, Ankit?
one of Upasana's question that if you have uh, swelling of the nerve or thickening of the nerve distal to the carpal tunnel, should we take that? So the most easiest or the most practical thing to do is you measure the nerve wherever it's the thickest. Now,
Right.
whenever a nerve gets compressed, there's a change in the veno-lymphatic flow, or the endoneural flow. So it's, we are classically, we teach that the nerve always gets enlarged or swollen proximal to the compression. So it's not a rule, it can even get swollen distal to the level of compression. And there have been so many times when you actually see a thickened nerve distal to the level of compression, not just in carpal tunnel, even the ulnar nerve, even even common peroneal nerve. So it's a good idea to scan proximal as well as distal. For that matter, it is actually the distal carpal tunnel which is the most narrowest part of the carpal
Impressive.
tunnel rather than the proximal carpal tunnel.
Proximal.
So
Right.
it's a good idea to scan right beyond the carpal tunnel. So
We should
that's
take
what
the
I feel.
maximum thickness. Why it is
Maximum thickness. So, Upasana, you mentioned something about the elastography also. And let me make, so wherever nowadays, the strain elastography has not much role, but shear wave elastography has a lot of role to play in giving an idea about the median nerve or any nerve getting entrapped and compressive nerve. So there's a general rule with shear wave elastography. With the tendons have got a low elasticity, but when they get involved, say they have tendinopathy, they become soft. So the velocities reduce. Shear wave velocities reduce, but it is a reverse for the nerves. In the nerves, when the nerves get involved, they become stiffer. So when they become stiffer, the shear wave elastography velocities increase. So that increase in the velocity with side-to-side comparison can give us, in a symptomatic patient, a good diagnostic confidence that we are dealing, and so we can go more diligently to find out where exactly we should measure, instead of just, going and saying it all looks okay, or there is a very narrow, mild compression. Also about the notch sign. How many people have had a good experience with notch sign in a long axis at the level of the lunate, where the flexor retinaculum is there? I find that is a very useful sign.
Yes, ma'am. Yes.
Extremely useful, because whether it is the thickening of the flexor retinaculum does get involved, reactive or per se. And I always, even if it's very subtle, I always find that little compression and a very subtle notch. And when you go side to side, so I think that particular descriptor which goes in the report or maybe in your head for a diagnostic confidence is a great idea for us to, keep in mind where there is a compression of little bit of a retinaculum. What do you
Can
say?
I make a comment on elastography?
Please, Rajesh, yes.
So honestly, I don't know. Whatever I have tried now, maybe I'm not working with the best of equipment, but whatever I've tried right now, I have always seen the strain working better and giving little more information as compared to the shear wave. The shear wave till now has never given me, persistent information or, what I expect or, in terms of the color filling or whatever. I don't know what is the opinion everyone has. So I mean, what you were saying, I mean the change in velocity and all, but how I do agree there's a lot of literature which is come out over that. In general, in MSK, I have not seen it working really very well. So I don't know what is everyone's opinion on that.
It is, I think then we are, we need to be more accurate with our technique. So for any area, if you're going to take a box which is going to be zoomed, the area that you need to focus, you zoom it to the maximum, and then you narrow your shear wave box to the minimum, just in that area. Because if this combination is not going to be there, your shear wave velocities will not be accurate. So you zoom out the area of pathology and you narrow the box just to fit that pathology. And then you put your 5 or 3, I do 3. And if you put your the the markers there for shear wave, you're sure to get it. It's at least in tendons and nerves, I'm finding it helps me a lot. I do it very routinely. I give my reports of shear wave very routinely, so that just in case somebody else is there, but it works very well. And it works the best in very early cases.
Yeah, that I do agree. So I mean, I am quite happy, honestly, using the strain. In fact, I always think that the strain gives, like, even things like epicondylitis or whatever, that very early changes. Sometimes I just saw one patient 2 days back. You can see that softening, but without this. But again, I was not getting the same consistent information with the shear wave. Maybe I think I'll try what you said. Just narrowing that down to a very
Right. Yeah,
specific
because
area.
you have to have a very clear idea about the pathology. You can't take a very big box. You just can't take a nerve looking as you take it in long axis scan at the level of median nerve and flexor digitorum tendons. You can't take a very big view of all the structures together. You have to narrow that down to that one pathology, zoom that area, now put in your shear wave box, narrow it only to that pathology, and then you start putting your color boxes ke andar, whatever you take as your color signals. You put your markers there for the velocities. Just try it and see. It works very well. It works very well.
Okay, I'll try that. Thank you. Thank you.
Also, Upasana, I was just thinking that is there anything in CTS which can be misdiagnosed as CTS? Any pathology which can be misdiagnosed as CTS, and how do we check on that?
Yeah, ma'am. Are you asking about the nerve entrapment?
No. Something that I came across about a couple of months ago. It was very interesting, and I'm sure that double crush syndrome. Have you heard of that? A double crush syndrome is a very important pathology. It's not a very common pathology, but it does. So there is a cervical radiculopathy.
Yeah.
Yeah. And
Yes.
then it presents as carpal tunnel.
Yeah.
And you say that it's carpal tunnel, but it's actually coming right from here. And there's a combination of radiculopathy, which ultimately leads to median nerve. And so
That usually at the level of C6, I think, ma'am.
correct. And the only thing that works for us is that there is a general kind of weakness that the patient says in the entire arm instead of just at the wrist.
Yes.
Is the entire arm. So that was a very interesting case. A young man, 17 years, had a bike fall, and he presented with that. So it took us a long time. I was not too sure, but our consultant was extremely interactive. Aapne ye dekha, aapne wo dekha. So it just kind of fixed in my head that double crush syndrome is an entity that can always be confused with carpal tunnel syndrome.
Yes, sir. Okay.
Yep.
Could we go
So
for the
I don't know. Do you examine your patients clinically also for the carpal
Yes,
tunnel?
ma'am. Yes, ma'am.
You
I
do.
show him, yeah, and the tinel
So,
side especially.
so early के अंदर क्या मिलता है? I mean, do you find something? Normally the only thing that I find if I clinically do the phalanx or this tinel is one thing, but that if you do it really strong, even a
Yes.
normal person sometimes jumps. So I don't believe in tinels. मेरे को ज़्यादा confidence नहीं है. Because some people are very sensitive and they jump anyway, and then you go on and overdiagnose. So, what all other factors in clinical would you want to consider to make our diagnosis a little robust?
So, Dr.
Yeah.
Upasana, basically, do you have a checklist for what things you look at? Like what you're going to document in a patient like carpal tunnel? Like, let's Like how you, while doing an obstetric scan, you have a checklist. You do
Correct.
this. So what
Yeah.
all things do you look at?
I should make one
Document.
slide, I think. First, I used to describe the morphology of the nerve at that level. If it is swollen, if the outline is fuzzy, how the vesicles are, it's maintained or not, the normal morphology, if there is any vascularity. And I don't do elastography sharing, but I used to do the strain elastography to see the stiffness and the dynamic study also. Then I see for the carpal tunnel, all the parameters we said, the CTS at the level of the inlet, then the difference of the area between the pronator quadratus and inlet level, then distal flexion, distal flattening ratio, and the carpal tunnel flexor retinaculum elevation. All four parameters I used to give. Then look for the muscles, adjacent muscles. Then if there is any tenosynovitis, arthritis, or ganglion cyst, like all the causes I have shown in my slides, I used to see all around the wrist for other structures, if it is there. But as ma'am said, the lumbrical intrusions are very rarely seen actually. Incursion of the lumbricals or like this. If it is not come into our eyes, like it's going, it's a muscle close to the median nerve, it's not going out, then perhaps it will catch our attention. Otherwise, very rarely we use for muscle incursion into the carpal tunnel. That's all.
Would you suggest, Upasana, that if it's a borderline, not a very strong diagnosis, we do a side-to-side comparison and you give the CSA of
Of
the
course, ma'am.
other side also? So
Of course,
for
whenever there is any suspicion, we always should go for the opposite side. In any case of MSK ultrasound, even in a ligament also, we always compare the other side. And then it become more, it gives us confidence, more confidence to say it's something is abnormal. It's not like the other side normal, if the other side is normal.
how many times have you come across that the NCVs are normal and you're finding median carpal tunnel syndrome? I find that a lot of times the patients are coming one way or the other. Either they're having NCV positive and I'm not finding CTS, or how accurate is NCV, Ankit, Rajas? Anyone, any experience with the
So,
NCV studies and comparison with the
so a lot of, I mean, this is what I see from day-to-day practice. A lot of NCVs are very non-specific and they're very ambiguous. In fact, there are only maybe 2 or 3 places in Bombay. I mean, I can say that, the hand surgeons, before making that call, they say, okay, तुम वहाँ पे जाके एक बार repeat करवा के आओ. So, they can be very ambiguous, the nerve conduction studies and how you interpret them.
Upasana,
So,
you've got 2 questions in your chat box from Dr. Prasanna and Dr. Renu. No, I totally agree that in a similar manner, I have come across a lot of MRIs and they just don't correlate with my ultrasound. I mean, their CSAs are like 17, 19 millimeters square. Any experience there? And there are quite a few studies. So because they were just not matching my ultrasound findings, I went on to do it. And there is a huge big cohort study, MRI, even I think radiographics or radiopedia somewhere. They say that MRI findings don't correlate well with the ultrasound. So what is the gold standard then?
the gold standard is still the NCV.
Yes.
Ah,
The gold
NCV.
standard in the nerve conduction studies.
Are they?
Yes.
Ah,
Yes.
no.
Although we might not like it, but the
No,
gold
we don't
standard is
like
still
it.
the
No,
nerve
no, even our
conduction.
orthopedicians don't like it, Ankit. No,
Yes.
otherwise they won't. If they have an NCV positive and they send the patient to us, I get that a lot of times. And they say, कि एक बार देख लीजिएगा, NCV positive है. And because they want to do even a steroid injection or something, but they're not convinced because the patients are actually, I don't know, I think NCV studies are very random. I don't know.
Yes,
I have very
they
little.
are random. They are random, but
Yeah.
they are still
It
the
is in the
gold standard.
literature that they have mentioned that NCV is the gold standard.
I
It is
know
the
it
gold standard.
does. अरे
Yeah.
अरे मोहित एक
In
बार
in in fact,
MRI को भी
ultrasound
gold
is
standard
optional.
बनाया हुआ है.
Yeah. So
MRI को भी
because
gold.
we don't have an India-based study, अपना
But
student should participate and make a cohort complete, comprehensive one, where we can say that it doesn't match. But gold standard in the literature always is NCV.
I
I
don't know.
think
We can
NCV done by a perfect person is most important because
वो तो
here also
अल्ट्रासाउंड
we
में
are,
भी लागू पड़ता है ना रे.
हाँ लागू तो
हाँ,
पड़ता है लेकिन मोहित ने तेरे को
नहीं
बताया
here
लाइक फॉर
also
एग्जांपल मेरा
I am
एनसीवी अगर मैच
saying
नहीं कर रहा है ना और मैं उसको
हाँ,
जाकर बोलती हूँ मेरे में नहीं आया तो दोबारा करके आओ वो मैं एनसीवी दोबारा नहीं करवाऊंगा इतना सुइयां चुभाते हैं ऐसा करते हैं सो आई एम सॉरी
See,
डॉक्टर प्रसन्न यू वर सेइंग समथिंग
actually I am seeing 2-3 doctors here. So one is very accurate at the even nerve level, at which level that she is giving that particular diagnosis. But at some places, some other doctors, they, particularly neurophysicians, they are doing NCVs. They are usually writing it very vague. So that is what I am
yeah,
seeing.
मतलब it is ultimately expertise. My hand surgeon always says ये tinel sign positive आ रहा है. So it is. I understand that, but when Ankit said, I would agree because it's there in the literature that NCV is the most diagnostic tool.
It's
I
a
agree.
confirmatory test.
But with our data, we can publish it if we want to. We have so many people doing, wrist ultrasound, doing carpal tunnel. Let's pull in the data and find out.
I think that's a great idea. If we have 6 investigators and 6 investigators take the 3 parameters and put NCV as the gold standard and compare, and all 6 of us sit down and put our data into a sheet. I think we will have
Yeah.
something very strong come out of it. I agree with you. But
In my practice, the hand surgeon refers for NCV only the CSA is on a borderline level.
correct.
So if I mention the CSA of say just 12.5 or 13, he has a strong clinical suspicion of CTS, then only he will refer a patient for NCV. Otherwise, most of the times he depends on our CSA values
No, I
and the
think that's a very
clinical
fair
correlation.
Mm.
That's because Dr. Ketkar, we work in standalone clinics. And standalone
Yes.
clinic में NCB के लिए किधर और भेजो, अल्ट्रासाउंड के लिए किधर और भेजो. So they prefer कि बाबा नीचे के नीचे अल्ट्रासाउंड हो जाएगा, जाके करा के आओ. So
No, but when we give borderline
institute.
CTS, when we give borderline CTS, they always refer a patient for NCV. Not every patient they refer for NCV. Out
No,
of
what
10, they might refer eight patients for ultrasound. And at least in my practice, my hand surgeon refers only for NCV if I give a borderline CTS report. I mean CSA, borderline CSA values.
So even I agree with Ketkar sir. I think even I mean some of the places it's not very consistent in terms of which patients are going to be sending for NCV, which they don't. So it's I don't know. And the reports, yeah, I agree. They are sometimes so difficult to even comprehend. So finally, they
I
are
think
going to be relying on on the ultrasound or whatever to say that what do you think?
Ultrasound and clinical
at
picture.
my place, at my place, my regular plastic surgeon sends patients, and he sends it mainly for the confirmation, findings for confirmation for operation or documentation. He doesn't do much for NCVs, only for clinical diagnosis there, and then for confirmation before operation, he sends for the cross-sectional area.
See, I feel, you have to understand that carpal tunnel syndrome, it's like, like myocardial infarction. Like the ECG tells you that there is a problem.
Yes.
It's ultimately the imaging, that angiography tells you where is the problem. So I think ultrasound, what it does is it gives you an anatomical perspective to that problem. Although the gold standard is a nerve conduction study, it tells you, it gives you physiological information that yes, there is some problem with the nerve, there is some slowing of the nerve conduction. But what ultrasound tells us or gives the surgeon is an anatomical perspective that what is the morphology of the nerve? how badly is the nerve compressed? Is there anything else that I need to be aware of once I go in? So if I go in, do I have any surprises interrupt? I don't want anything like that, because nowadays more and more people are going into minimally invasive surgery. They want smaller and smaller scars, and then once you go in and you see, oops, there's so much of tenosynovitis, so that one little scar can go all the way to the hand, and then it becomes difficult to explain to the patient. So that's where ultrasound really, really comes in a big way.
And one added advantage of NCV is that it shows the level of the conduction defect. It shows the level, and that can reduce the part to be examined by ultrasound to see the other structure, adjacent structure, and to confirm the test, confirm the.
But I think Ankit made a very valid point. I think we need to understand from here and take a message home. Why is an ultrasound sent if the patient is suspected of CTS? Now, that's a valid question. And what Ankit has said is a $1 million statement, that the consultant knows that the patient has CTS. He knows that. What he wants is to rule out what could be the cause. Is it tenosynovitis? Is there a ganglion sitting there? Is it a thickened retinaculum? Because there can be so many other causes, as Dr. Upasana showed the dynamic scan. And if it's an extrinsic pressure, your nerve is going to move side to side, even the patient is having carpal tunnel syndrome symptoms. So I think that is a wonderful thought that we should all carry back, that we need to understand and you need to explore all the reasons. And then as Anupma, what Upasana said was that patient is having carpal tunnel, but your carpal tunnel at wrist, your median nerve at wrist is absolutely normal. So you need to explore the other areas as well. You need to go more proximally. You need to go at the mid forearm level. You need to go at pronator teres level to understand where could be that compression. So Ankit, you made a very fantastic point here, that it is not always about giving the median nerve or NCV. It's about giving a diagnostic precision as to why that carpal tunnel symptoms, compressive symptoms are there. That is a fantastic, very nice, absolutely right. And that is, of course, I think the strength of ultrasound, that we can actually tell the consultant that where that compression or those symptoms are coming from. So we need to rule out all the causes. For all you know, it's just an accessory muscle sitting there. And like Dr. Renu asked, that can a bifid median nerve cause carpal tunnel syndrome? Of course it can. It does. And the difference, as Dr. Basna said, was that at the level of pronator and at the carpal tunnel, if the difference is greater than 4 millimeters square, then the bifid median nerve is causing carpal tunnel syndrome. So that is fantastic.
Yeah, and one more thing that you need to know about bifid median nerve is the bifid median nerve itself has so many variations that, it might be bifid in the distal forearm and then again becomes single. It might just split for a while and again become single.
That is one of my question, how to measure in that cases. If we find a single median nerve, then as you go distally, it divides. Then how to take the parameter?
You add it up. You add it up.
Yeah. I think we add it.
Yeah. You add up the areas. See, it eventually the parameters remain the same. The morphology of the nerve is important, and it is just an anatomical variation. So if it can also get involved, as Nidhi said, in any form of extrinsic pressure, it can get involved. So once it goes into the carpal tunnel, apart from the two stumps, you treat it as a carpal tunnel, irrespective of whether single or bifid.
Right.
So in short, Mohit, you add A plus B, and together, if it is more than 12, it is still the 12 which we take as a cutoff? Or
Yeah.
Yes. Okay.
So, see, there will be some instances where you can have a bizarre presentation wherein the patient has pain only along the middle finger. So that still could be a carpal tunnel syndrome. It will not be along the thumb, along the index finger. She'll say that, no, I have pain only along the middle finger. So in those kind of cases also, if there's a bifid median nerve, you will see only the ulnar trunk getting involved, or maybe sometimes only the radial trunk getting involved. So that is also a possibility that you might be able to come across. So it can happen in any kind of permutations and combinations. So these kind of things.
Absolutely.
So that's where I think ultrasound can really play a role in atypical presentations of carpal tunnel syndrome.
Also, there may be communication between ulnar and median nerve also at the level of the hand or in the forearm.
There is an overlap.
That will present with atypical presentation.
Right. Right.
Okay.